Hello everyone, welcome to Easy Medicine. The topic that we're going to discuss today is JVP. Why JVP? Because JVP is a 5-star PYT. I called it 5-star PYT because this topic has been repeated 5 times in the last 7 years of the NEET and INI set exams. If you can see here, the topic has been repeated in INI 18, INI 19. Here INI stands for the AIMS exam there was no INS set at the time, and then NEET. So eventually the topic was repeated 5 times in the last 7 years. That's why it is a 5-star topic. Okay, and by the end of this video you will be able to answer each and every question from JVP, and also you will be able to appreciate clinically what is a JVP and what is a carotid pulse and apply so. So let's delve deeper into this topic with the following outline. We'll firstly go with the definition and then the method of examination, JVP versus carotid. How are you going to delineate them clinically, and what are the waves and what are its abnormalities? So let's start with the definition. So JVP stands for jugular venous pulse or jugular venous pressure. You call it as jugular venous pulse when you are able to appreciate an oscillating vertical column of blood in the right internal jugular vein, which reflects the pressure in the right atrium, which reflects the pressure changes in the right atrium. That is nothing but the jugular venous pulse. You call it as jugular venous pressure when you are able to measure the height of the vertical column of blood in the right internal jugular vein. Mind you, this is not an external jugular vein. Of course, the external jugular vein is very easily visible in the superficial plane, and it is also containing valves. That is why we don't consider the external jugular vein for measurement of JVP. We consider only the internal jugular vein. So look at this image. So here we have the right atrium. Draining into the right atrium, we have SVC, and draining into the SVC, we have the right and left brachiocephalic veins. And draining into the brachiocephalic vein, we have the internal jugular vein and the subclavian vein. As you can see, the right IJV is in direct communication with the right atrium. That is why the right IJV is taken for the JVP measurement, but not the left atrium. And also the IJV is valveless, and the pressure changes in the right atrium are easily visible in the right IJV. And look at its anatomy. The right IJV is taking its origin beneath the clavicular head of the sternocleidomastoid, and it is gradually ascending upwards, upon which the sternocleidomastoid is crossing. Okay, and you can see in the neck as well, the right internal jugular vein is lateral to the carotid artery. These are a few points that you need to note from these images. Now, this is the method of examination. So firstly, place the patient at an angle of 45 degrees with the horizontal. 45 degrees with the horizontal, and take a couple of scales. Erect a scale vertically from the sternal angle upright, and take another scale. Keep it horizontal or perpendicular to the vertical scale, and with that scale measure the upper limit or the oscillating column of blood in the right internal jugular vein, if you are able to appreciate it. Then the distance between the horizontal scale and the sternal angle gives you the vertical column of blood. Okay, if you look at only the height of the column that is visible, if it is less than 4 centimeters or together from the right atrium, less than 9 centimeters is considered as normal. Why 9 centimeters? Because there is a distance of about 5 centimeters between the right atrium and the sternal angle. Okay, so I would like to take an analogy here for a better understanding. See, consider this bottom end of this flask as the right atrium and the stem as the superior vena cava, and here we have the internal jugular vein. A small part is highlighted with a red colored box. What I meant to represent here is this part of the neck in that box. Okay, keep that analogy in the mind, and I'll try to explain you easily. See, this is what I told you about the flask with the right atrium and the internal jugular vein aligned vertically in a straight line, and then fill the right atrium and the SVC with blood. Okay, now you are able to appreciate. Now this is the neck, right? So this is the neck, and even though the jugular venous pressure may be elevated to some extent, it is not yet visible in the neck when the patient is sitting upright like me, since the column is vertical. Now tilt it to 45 degrees. Tilt it to 45 degrees. What has happened now? The blood column, see, observe the vertical height. The vertical height is yet same. The vertical height is yet same, but since the patient has tilted at an angle of 45 degrees with the horizontal, now we are able to appreciate the upper level of the oscillating column of blood in the internal jugular vein in the visible part of the neck. That's what I highlighted, the small box. Now, if the patient lies down, again it disappears because the vertical column of blood is right into the skull. Right. So that is why the 45-degree angle is important. But if the IJV is very much elevated, and then even if the patient is sitting upright, the IJV may be elevated. So if the column of blood is there in this box, even when the patient is upright, then you may be able to appreciate the jugular venous pulsations there. Hope you understand this. Now see, on the right side, what do you appreciate? Of course, you can. So, this one is the anterior jugular vein. We are not concerned about, even though it is very prominently oscillating and you are able to appreciate some levels there. The pulsations that you are appreciating in this area are more important. And look at the next image. You have pulsations here. These are much more medial. The pulsations that you saw here are the internal jugular venous pulsations, and you can see them tracing up to this level. And here in the right image, you can only see the carotid pulsations. I'm sorry if I am distracted. So let's differentiate JVP from the carotid. So JVP is better seen. Hope you have appreciated in the last image, last video, short video. The JVP is better seen and can be obliterated. So if at the base of the neck, if you keep the hand here and you put some pressure, since it is only venous flow, it may be obliterated. And you can see two troughs and two peaks and two troughs, otherwise called as two positive and two negative waves. You will be eventually understanding them, and it is seen more laterally when you compare it with the carotid waves, and it has a definite upper level that is present depending upon depending upon how you place the patient. And retractile pulsations, that is the negative waves gives an retractile impulse. This changes with the position. Right, you have appreciated it, right? The jugular venous pulse changes with the position, respiration, as well as abdominal compression. And when you look at the carotid pulse is better felt than it is seen, and it cannot be obliterated. You cannot obliterate an arterial flow, right? And it has only one positive wave. The carotid pulse is obviously seen medially, as you have seen in the anatomical part, and the definite upper level is not seen, and it is an expansile pulsation. The arterial pulse will be bulging outwards, right? And it does not change with the position, respiration, and abdominal compression. So we are going to discuss this, but don't be overwhelmed with this image. We'll go towards it gradually. So what is happening in the normal sinus rhythm? So this is a normal jugular venous pulse or jugular venous pressure wave. So we have an A wave, C wave, and a V wave, which are positive waves, and there are two negative waves, which are X descent and Y descent. So look at it now. You don't have to you don't need to have a very good understanding of this each and every part. If you remember this simple mnemonic for the remembrance of what wave corresponds to what event in the cardiac cycle. So the A wave, A for A stands for atrial contraction. Okay, A wave is seen in atrial contraction or atrial systole. X wave is seen in atrial relaxation. X wave is seen in atrial relaxation. And then the C wave, C for cusp or C for closure. So C wave corresponds to the closure of the tricuspid valve. But what happens after the closure of the tricuspid valve? The phase of the cardiac cycle, which is isovolumetric ventricular contraction. Isovolumetric ventricular contraction. Then followed by the V wave, V for V, ventricular contraction, or you can also remember venous filling of the atrium. Okay, V for the ventricular contraction is we are not concerned about the ventricular contraction here, because whatever we talk about, we are talking about the atrial pressure changes, right? And then lastly, we have the Y wave or the Y descent, which corresponds to the atrial emptying. There is a Y in empty and there is a X in relaxation. That is why you can understand it as atrial relaxation, that is an X wave, and atrial emptying for a Y wave. Okay, hope this is simple for you. You can easily remember this even if you clearly don't remember the events in the cardiac cycle. Just by remembering these letters, you will be able to deduce what event of the cardiac cycle corresponds to which wave. Now, what are the causes of raised JVP? So, depending upon the mechanisms, when there is a right heart failure, obviously the blood may not be able to enter into the right atrium. That is why even a right heart failure or car pulmonale is nothing but the right heart failure resulting from a long standing pulmonary disease, right? Any kind of obstruction throughout the flow of blood, that is an SVC obstruction, or next level tricuspid stenosis, then go forward pulmonary stenosis, and then go forward pericardial tamponade, constrictive pericarditis. See, the constrictive pericarditis and the pericardiac tamponade, they are not going to allow the blood to enter into the heart. That is why the right atrial input is very much reduced and the blood flow in the IJV is clearly visible. And then the fluid overload states like the renal failure, and then iatrogenic. The other causes are the tricuspid incompetence, the RV infarction, and ASD, the atrial septal defect. So we'll clearly see the most of the questions come from the different waves now. The A wave, which stands for the atrial contraction. A wave may be absent in the atrial fibrillation. We have spoken about the atrial fibrillation in a separate video completely. You can go through it. Since the atrium is not able to produce an effective atrial contraction, this is only vibrating or fibrillating, a proper A wave may not be generated, right? And then comes a giant A wave. The giant A wave is seen in the tricuspid stenosis or tricuspid atresia, and then right ventricular hypertrophy, and then the pulmonary stenosis or pulmonary hypertension, right atrial myxoma, which again acts as a tricuspid stenosis. But let's understand this by using this chart. Hope you understand this entire flow. So internal jugular vein drains into the SVC, and both SVC and IVC drains into right atrium. Across the tricuspid valve goes into the right ventricle, across the pulmonary valve goes into the pulmonary aorta, and then gets oxygenated at the lung, and the blood enters into the pulmonary veins. Pulmonary vein drain into the left atrium, across the mitral valve into the left ventricle, across the aortic valve into the systemic aorta. That is what this circuit is, and you are going to see this circuit throughout the cardiology lectures which are done by me. Okay, so hope you got the gist of it. Now let's apply. So the right atrium, we are talking about prominent A wave, right? It means that the right atrium is pushing blood against resistance. Where is the resistance now? So the tricuspid valve, when it is stenosed, may exert resistance. Next, come to the right ventricle. When the right ventricle is hypertrophied or when the right ventricle is in failure, again the same may happen. When you come to the pulmonary valve, pulmonary hypertension or pulmonary stenosis again can develop the prominent A wave. Hope you understand. Along the circuit, wherever there is resistance, if there is resistance, the right atrium has to pump more and more against resistance, and hence A wave can be prominent in the internal jugular vein. That is what you need to understand. Now, A wave can be prominent, can be very prominent. When it is very prominent, you call it as the cannon A wave. When it is prominent, you just call it as a prominent wave, and when the A wave is very prominent, it is called as a cannon A wave. Now understand. So when the atrium is contracting against resistance, the A wave is going to be prominent. What if the atrium is contracting and the ventricle is also contracting? So the tricuspid ring, which is located in between, is also pushed upwards into the atrium because of ventricular contraction. Now, how do you think will the A wave be? A wave will be very prominent. That is what you call it as a cannon wave. Cannon waves can be regular or irregular. So what are its causes? Don't worry, I'll list them, then I'll explain. So regular cannon A waves are seen in junctional rhythm and atrioventricular nodal reentrant tachycardia, AVNRT, or a ventricular tachycardia with 1:1 retrograde conduction and 2:1 AV block. An irregular see in the image, and the pacemaker of the heart is not SCI node now. This is in relation to the junctional rhythm and AVNRT. You can see the pacemaker here. This is the pacemaker now, and this is going to give out impulses to the both atrium and ventricle. Okay, so both the atrium and ventricle are contracting simultaneously, thereby resulting in a cannon A wave. Okay, now come to the irregular cannon A waves. What are the causes of irregular cannon A waves? A complete heart block where the AV dissociation is seen and multiple premature ventricular complexes, ventricular tachycardia, ventricular pacing. What happens in ventricular tachycardia and ventricular pacing? The atrium is going to beat at the rhythm, at the rate that is set upon by the SCA node, whereas ventricular tachycardia means an ectopic focus in the ventricle is beating the ventricles. Both of them are not under the same pacemaker now. So you will understand further by looking at this image. See, so here there is an AV dissociation. Now the atrium is not conducting impulses into the ventricle, and atrium has a separate pacemaker under which it is receiving impulses or under which it is contracting, and the ventricles also have a different pacemaker now. But both of them are not synchronized. That is why some of them may overlap and may result in a irregular cannon A wave. This is for the further understanding. See, if there is a normal in the normal sinus rhythm, the top one that you see here is an ECG wave, just for the understanding. After a P wave, there is atrial contraction, and after a QRS complex, there is ventricular contraction. After a P wave, we have an atrial contraction. After a QRS complex, we have a ventricular contraction, but both of them are not happening simultaneously if you observe. Now, what happens in a premature ventricular complex? So, in a premature ventricular complex, here we have a premature ventricular complex and it has coincided with an atrial contraction. Here there is no coincidence, here there is no coincidence, and here the ventricular contraction has coincided with an atrial contraction as well. This is the scene for cannon A wave. This is the scene for a cannon A wave. Now what happens in a complete heart block or a ventricular tachycardia or a ventricular paced rhythm where the atria and ventricles are under different pacemakers? See now. So the ventricles are beating on their own, whereas the atria are beating on their own. Here you have a P wave, here you have a P wave, another P wave may be embedded here. So we have a P wave which are occurring regularly and QRS as well which are occurring regularly, but a few of them may coincide and may result in an irregular cannon A wave. Hope this explanation is quite clear. Now we next move on to the V wave. So the V wave may be diminished or it can be prominent. The V wave is diminished when the patient is having hypovolemia, and it is prominent. See, the V wave stands for venous filling of the atrium. Okay, so now when the atrium is not only receiving blood from the veins but also receiving blood from somewhere else, the V wave can be prominent, right? So what is the other way where the right atrium will receive blood? The right atrium may receive blood from the left atrium through an ASD, or it may receive blood from the tricuspid valve as well with tricuspid regurgitation, right? So these are the causes: tricuspid regurgitation, and then comes, see, in tricuspid regurgitation, the blood is flowing from right ventricle into the right atrium, and V wave can be prominent. In ASD as well, the blood is received from left atrium into the right atrium. Sometimes there is an effect called as Gerbaud effect where the LV also communicates with the right atrium. This may also happen sometimes. And finally, carpulmonale, where there is right heart failure. Again, right heart failure may be associated with the tricuspid regurgitation again. Now, see this chart or a table that has been given in Harrison's where the tamponade, constrictive pericarditis, and restrictive cardiomyopathy are differentiated. This looks like this takes a lot of mental effort, but no, because we have a beautiful mnemonic for remembering the essential points from this. So the mnemonic is rupee tax. Okay, pay some attention here. Everything is going, you are going to deduce each and every point from the mnemonic rupee tax. Okay, so remember here, prior If a letter comes prior, then it is prominent. If a letter comes after, then it is absent. Okay, you'll understand. So here R stands for the restrictive cardiomyopathy. R stands for restrictive cardiomyopathy. P stands for constrictive pericarditis. P for pericarditis. And here Y is a Y wave, and T stands for tamponade, cardiac tamponade. And X is nothing but an X wave. Okay, so here the R comes prior to Y wave and prior to X wave, and hence Y and X are prominent in restrictive cardiomyopathy. Now for P, the P comes prior to Y and X, and hence both X wave and Y wave are prominent in constrictive pericarditis. And in relation to T, the T comes after Y, and that is why the Y wave is slow or absent in cardiac tamponade. And T comes prior to X, and hence the X wave is prominent in tamponade. Okay, if you want, you can just repeat it. So I'll again put it in the text. So in cardiac tamponade, there is a prominent X descent and an absent or a slow Y descent. And the Kussmaul sign is negative. See, normally, in normal individuals, when you inspire, there is negative intrathoracic pressure, and the blood fills from the superior and inferior vena cava into the right atrium. Okay, the JVP actually falls in inspiration. That is a normal response. But if the heart is not accommodating blood with increasing negative intrathoracic pressure, the blood will not flow inwards into the right atrium and the JVP is elevated. That is called as the Kussmaul sign. The rise in JVP with inspiration is called as the Kussmaul sign. That is seen in the constrictive pericarditis, restrictive cardiomyopathy, pulmonary embolism, right ventricular myocardial infarction, whenever there is right ventricular failure. Okay, but it is negative in cardiac tamponade. That is the only exception. We can talk about it in detail when we talk about the pericardial diseases. For now, just remember, Kussmaul sign is negative in cardiac tamponade, whereas it is positive in constrictive pericarditis as well as restrictive cardiomyopathy. Now, in constrictive pericarditis, the prominent X descent and it is the prominent Y descent or a rapid Y descent. The Kussmaul sign is positive. And in relation to the restrictive cardiomyopathy, both X wave and Y wave are going to be prominent, and the JVP is obviously elevated in all of them. Okay. Now, if you have understood the mnemonic itself, it is sufficient. But yet, we are going to try and reduce the mechanisms for the variations in X and Y descent as well. So, X descent is absent in tricuspid regurgitation. Now, think X stands for atrial relaxation, right? The atrium is relaxing. When will it not relax? When the blood is being received from other hole as well. So while the right atrium is relaxing, it is obviously receiving blood from SVC because it is valveless and it is giving the blood into the right atrium all the time. But if it is also receiving blood from the right ventricle, then the X descent is slowed down or absent. Okay, and X descent will become prominent in tamponade and constrictive pericarditis. That's what we understood in the mnemonic as well. Now in Y descent, there happens to be a slow descent in tricuspid stenosis and right atrial myxoma. Of course, the right atrial myxoma acts like tricuspid stenosis again. But see, when is Y happening? Y is nothing but atrial emptying. Empty has a Y, and hence Y descent is associated with atrial emptying. When will the atrium not empty into the right ventricle? When there is an obstruction between at the level of the tricuspid valve, right? So when there is tricuspid stenosis or right atrial myxoma, the emptying from the atrium into the ventricle is slowed down. That is why a slow Y descent may happen here. And even in tamponade, okay, and a rapid descent will be seen in severe tricuspid regurgitation, where the tricuspid valve annulus is increased so much where the to and fro movement across this valve is going to happen rapidly. Okay, and hence there is a rapid descent across the tricuspid regurgitation as well. And it is also seen in constrictive pericarditis and severe right ventricular failure. Kussmaul sign. Like we already discussed, Kussmaul's sign is nothing but rise in JVP with inspiration. It can be seen in constrictive pericarditis, restrictive cardiomyopathy, right ventricular MI, right heart failure, pulmonary embolism, constrictive pericarditis, cardiac tumors, and tricuspid stenosis. Okay, it is not seen in cardiac tamponade. If the JVP is normal, that is less than 9 centimeters of water, but still you suspect heart failure, then you can elicit one of these two maneuvers. One is the hepatojugular reflex, another one is the abdominojugular reflex. What do you do in hepatojugular reflex? You will apply firm pressure at the right upper quadrant for 15 to 30 seconds with the fist like this. Okay, and you will observe for elevation in the JVP. Why will be there some elevation in the JVP? Because there is increased venous return from the hepatic circulation. You can also elicit an abdominojugular reflex, which is similar to that of hepatojugular reflex, but you are going to apply pressure at the mid-abdomen for 10 seconds and again observe for the elevation in JVP. Here the principle is there is increased venous return from the splanchnic circulation. Okay, so this is all about the jugular venous pressure. Hope you understood, hope you liked it. If you like, please share and subscribe to the channel. We'll meet in the next one. Thank you.